Good afternoon, everybody. My name is Eszter Virág-Tulassay, and I would like to present my PhD thesis. I am working as a resident doctor at the Department of Orthopedics of Semmelweis University, and my vision is that in the future, shoulder dislocation will not be a long-term limiting injury for young people. So my mission is finding the best choice therapy for each patient with anterior shoulder dislocation. Because of that, I have two ongoing projects now, and I would like to present the first one, that is investigating the safety and the efficacy of different therapies for acute anterior shoulder dislocation. Shoulder dislocations are about 50% of all joint dislocation in the human body, and 97% of these being an anterior one. Acute shoulder dislocation are associated with a lot of pain and a lot of tissue injuries, but the biggest problem is that we don't know which is the best therapy for this injury. Conservative treatment maybe is enough, or we need a surgery, like soft tissue surgery that we call Bankart. So our aim is that there are currently no international recommendation for appropriate intervention, so we would like to provide an evidence on this problem. Our clinical question is really simple: which therapy is the best for the patients with acute anterior shoulder dislocation? So our population is the patients with acute anterior shoulder dislocation, and we would like to compare the immobilization in internal rotation, immobilization in external rotation, and the Bankart surgery. So we have two main outcomes. The primary outcome is the safety, like pain, complications, and redislocation rate. And the secondary outcome is the efficacy, like range of motion, return to sport, and scores. It will be a network meta-analysis, and our hypothesis is that Bankart surgery has the highest efficacy and the lowest rates for complications in acute anterior shoulder dislocation. If we have true, we can have for the surgeons to have and find the best choice therapy for each patient. You can see my systematic search that I made in 3 databases, and my search key that contains 4 domains. The first one is about the joint, the second one is about the injury, the third one is about the therapy, and the first one is about the randomization. During the flowchart selection, we started around 2,000 articles, and after the full text selection, now we have 35 articles. And you can see my first project progress, that we are waiting for the figures and the tables. But we have one finished analysis, like the redislocation rate, and we have a lot of ongoing analysis, like subluxation and positive apprehension test after the intervention, and the secondary outcomes. So now I would like to present our results. The first one is the redislocation rate with maximum 24 months follow-up time. You can see my network plot. Every node means an intervention like arthroscopic Bankart repair, immobilization in external rotation, and immobilization in internal rotation. The size of the nodes, how many articles we have in this topic, and the connection between the nodes means how many articles work for each comparison. The number of the studies was 10, and the total number of the patients in the network was 665. The league table shows us the comparisons between the interventions. On the right corner, I think so. On the right corner, you can see the direct comparisons, but we use only in the meta-analysis, the direct comparisons. And it's a network meta-analysis, so we use a network pool, which contains the direct and the indirect comparisons too. The network pool shows us that the arthroscopic Bankart repair has 18% less chance of redislocation than immobilization in external rotation, and 8% less chance than immobilization in internal rotation. Immobilization in external rotation has 45% less chance of redislocation than immobilization in internal rotation. We made the Sucre test that shows the P-score. P-score is the best one is 1, and the worst one is 0. So we can see that the arthroscopic Bankart repair has the best results, and the immobilization in internal rotation has the worst results. On the forest plot, we can see our 3 arms. The first one is the arthroscopic Bankart repair versus immobilization in external rotation. We have only 1 study, but the network estimate shows that the odds ratio is 0.18, and the confidence interval is significant. The second arm was the arthroscopic Bankart repair versus immobilization in internal rotation. We have 4 articles about this topic. And the network estimate shows that the odds ratio is 0.08, and the confidence interval was significant. And the third arm is the immobilization in external rotation versus immobilization in internal rotation. We have 5 studies, and the network estimate shows that the odds ratio is 0.45, and the confidence interval is significant. So, to summary, our result shows that our results is statistically significant and clinically really relevant. And my second outcome is the redislocation rate with more than 24 months follow-up time. As you can see on the network plot, we have a missing connection between the arthroscopic Bankart repair and the immobilization in the external rotation, because we don't have studies that compare these two interventions. The number of the studies was 6, and the total number of patients in network was 533. The league table shows the comparisons, like the direct comparisons and the network pool. And we can see that the arthroscopic Bankart repair has 14% less chance of redislocation than the immobilization in external rotation, and 12% less chance than immobilization in internal rotation. And the external rotation has 90% less chance of redislocation than immobilization in internal rotation. Of course, we made the Sucre test, and the p-score shows the same, that the arthroscopic Bankart repair has the best results, and the immobilization in internal rotation has the worst results. So we can say that our results in these outcomes are statistically significant and clinically relevant. Of course, we have strengths and limitations. Our strengths that we include only randomized controlled trials. Our participants was age-matched, and it's a complex, comprehensive analysis. But the limitation is that the low number of the participants, we can include only full publications, and we have some missing data for important variables in some studies. But the conclusion is really important. Bankart surgery has the lowest redislocation rate, and therefore the highest safety after 24 months of follow-up time. So maybe the implication for the practice is that maybe we should forget after the acute anterior shoulder dislocation, the immobilization in the internal rotation, and we should focus on the surgery therapy like Bankart surgery. The implication for research that further prospective data collection is needed to evaluate the efficacy and safety of available therapies. You can see my manuscript status and my journal selection, but we are waiting for remaining plots. So now I would like to present my second topic. It's investigating the safety and the efficacy of open Latagé surgery in recurrent shoulder dislocation. As I mentioned before, the shoulder is the most commonly dislocated joint, and the recurrence rate is really high without any intervention, almost 100% in the younger populations. The problem is the same, that we don't know which is the best therapy. Soft tissue reconstruction maybe is enough, like Bankart surgery, or bony correction of the glenoid is needed, like open Latagé procedure. So our aim is the same. There are currently no international recommendation for appropriate intervention, so we would like to provide evidence on this problem. The clinical question is simple: which therapy is the best for the patients with recurrent anterior shoulder dislocation? The intervention is the open Latagé surgery, and the comparison the Bankart surgery. The two main outcomes is the same as the first project, and it will be a meta-analysis. Our hypothesis is that Latagé surgery has the highest efficacy and safety in the recurrent anterior shoulder dislocation. If we have true, the clinical implication is really important, because we can help for the surgeons and we can help for the patients, so everybody win. You can see my preliminary research and my preliminary research key that contain 4 domains, like the first one, the joint, the injury, the therapy, and the randomization. So to summarize about our first results, maybe we can say that we found the best therapy for the acute anterior shoulder dislocations. And we hope that we can achieve the same results in the recurrent shoulder dislocation. But as we learned before from Peter Hegyi, hope is not enough. So thank you for your attention.
Thank you for the great presentation. Although I'm not an orthopedic surgeon, I really wonder what's the difference between these 3 types of surgeries that give...
2.
Or 2 types of surgeries that gives this big difference between them. So why Bankart surgery is so much better, that gives more stability? Is there like a crucial step, or it's so different from the other?
Yeah, the Bankart surgery is a soft tissue surgery when we should fix with sutures the labrum to the glenoid. And the open Latagé procedure is a bone correction. Then we cut the processus coracoidus and we fix to the glenoid with screws. So it's really massive. And because of that, the glenoid will be bigger. And because of that, the chance of the redislocation rate is lower. So open Latagé is a massive bone correction, and the Bankart surgery is just an arthroscopic soft tissue surgery.
Yeah. So it's shorter as well, and shorter healing time as well. So
yes,
absolutely better for the patient.
We hope so.
Thank you.
Congratulations to your excellent presentation. My question is that why did you decide to investigate these two different outcomes based on the follow-up times?
Thank you for your question. It's really important. We have two different groups because of the follow-up time. Because immobilization has almost the same redislocation rate in every follow-up momentum. But the Bankart surgery is really safe in the first 2 years. And after the 2 years, maybe became weaker, the soft tissue reconstruction, and get higher the redislocation rate. So because of that, I said on the conclusion that after the 24 months follow-up time, the Bankart surgery has the highest safetiness, and it's the important point.
Thank you for your presentation. I have a question regarding to the first project. As the secondary outcome, there was this table. And isn't it easier to, or are you planning to make a forest plot based on the results?
Yeah, it's a really good statistical question. Thank you. We don't have forest plot on the second outcome because we have a missing connection between the arthroscopic Bankart repair and the immobilization in external rotation. So we don't have a direct comparison. But the league table and the Sucre test can say that our results is significant and clinically relevant, so we don't need the forest plot. But thank you.
Well, I've got a question on, well, how large scar does a patient receive after surgery? So what is your suggestion for the patient, especially when the patient is old one? Does the patient need a general anesthesia for doing this surgery, which can be a problem with old patients with multi-morbidity, although this functionality of this joint is extremely important because it hinders the everyday life. So I can meet some patients with the problem that there is dysfunctional arm. That's a huge problem. So can you recommend these operations for the old ones?
Yeah, thank you for your questions. We focus on the younger population because this injury is the most common problem in the younger population. The older population, the problem is that when the shoulder is dislocated, the rotator cuff has a tear, a big tear, and because of that, we have to make another surgery, rotator cuff suturing. It's not a big surgery because we make it arthroscopical, so it just holds, and we can do it in a internervous blockade. So it's we don't need anesthesia. So it's a really different topic, the older and the younger population.